Hi, I'm Jen Rogers from Duke University, joining you from Durham, North Carolina, and wanted to share my approach to managing and understanding type 2 lupus. So many of the common symptoms in lupus, fatigue, nociplastic pain, brain fog, can be invisible and difficult to measure. These symptoms can often co-occur with impaired sleep, depression, and anxiety. They can be debilitating and result in poor quality of life. Fatigue and pain in lupus often present near that time of diagnosis and can occur during flares, but in many patients can persist during remission. They're not consistently associated with serologies or medications, even steroids. They are difficult to manage. These symptoms have led to a well-described discordance between physician and patient's perception of lupus activity and flares, and this discordance can impact communication, trust, medication adherence, and ultimately outcomes. We developed the type 1, type 2 model many years ago as a means to bridge this gap and to incorporate these type 2 symptoms as intrinsic features of lupus and autoimmunity, with perhaps a mixed or less clear relationship to inflammation. In this model, type 2 symptoms are not static. The activity and severity can change over time. We measure type 2 symptoms using patient-reported outcome measures, which are then informed by the history and physical exam. We use the polysymptomatic distress scale, but other PROs can be used, including the PROMIS 29 and short form 36. As a clinician, we measure type 2 lupus at every visit using a validated type 2 PGA, which is a global assessment of the severity and impact of type 2 on a 0 to 3-point scale, akin to the PGA. In analyzing our patients longitudinally, we found that type 2 can change with type 1 inflammation, so that traditional lupus activity, nephritis, arthritis, discoid rash, roughly around 45% of the time. Thus, slightly more than 50% of the time, type 2 symptoms don't have a clear association with type 1 inflammation. In further assessing these patterns of type 2, we have described two subtypes, intermittent and persistent type 2. Intermittent type 2 correlates with type 1 inflammation and thus can improve with immune-directed therapy, while type 2, persistent type 2, can persist and occurs independently from measurable type 1 and thus does not require further immunosuppression. The mechanisms of type 2 are quite complex and occur due to an interaction between genetics, environment, immunologic, hormonal, epigenetic, as well as social, societal, and psychological factors. Several psychosocial factors, including emotions, attention, prior trauma, stress, and really a variety of social determinant of health factors, can predispose, precipitate, and perpetuate type 2 symptoms in any individual person. So addressing type 2 really starts from a place of understanding that these symptoms are real. Pain and fatigue are highly complex and individual experiences. These experiences are constructed in integrated networks involving several neuronal regions in our central nervous system in connection with our peripheral and autonomic nervous system and our HPA axis. These neuronal regions that process pain and fatigue are also involved in processing several other cognitive functions: thoughts, memories, decision making, anticipation. And as our central nervous system is highly plastic, these regions and neuronal networks in our brain are influenced and easily altered by experiences in life, including the psychosocial factors I mentioned. Stress, poor sleep, trauma, or memories can have biologic impacts in behavioral changes, causing more isolation, immobility, anxiety, rumination that can ultimately result in symptom amplification. So, in accordance with our recent guidelines to improve the long-term outcomes of type of lupus, managing type 2 really requires a holistic approach. As a rheumatologist, we cannot manage all aspects of type 2, but we can partner with our patients and guide them on the path to improvement. As some features, as I mentioned, are related to inflammation, the first aspect of treating type 2 is managing type 1 inflammation following treat to target strategies, incorporating early DMARD and biologic therapy when appropriate. From there, managing type 2 takes a team and importantly requires buy-in and engagement from your patient. You have to meet your patient where they are. Some people may be ready and easily understand this multimodal approach. Other people, often in my experience, take time, several visits to build that trust, build that understanding. And some people may need to hear the message from many different people or in different formats, starting with the rheumatologist, but including pain therapist, physical therapist, peer support, or other avenues, videos or books, for example. The goal in managing type 2 is really to change that experience of type 2, improve the coping and impact of type 2, to return to activities, improve quality of life. When I counsel my patients, I explain there's not one medication or procedure that can manage type 2. I explain the type 1, type 2 model and the influence that a variety of factors can have on their experience of these symptoms. I set expectations that not all pain may resolve and that change takes time and practice, and that flares will happen because life is unpredictable, but these symptoms can be managed and they can be improved. I encourage people to set their own goals and try to identify those key factors that may be contributing, such as depression. Managing depression, of course, is important. Identifying immobility or isolation, finding connections, referring to physical or aquatic PT. Of course, we try to minimize narcotic benzodiazepines and prescription sleep medications and embrace novel and alternative approaches, whether that includes acupuncture, massage, vagus nerve stimulation, virtual reality, TMS, or leaning into mindfulness, distraction, gradual exposure, talking about pacing in order to prepare people to be proactive to manage these symptoms and flares. So, in summary, the type 2 model really captures that full range of lupus symptoms, understanding that these symptoms are biologic, cognitive, emotional, social, and contextual helps guide therapy and underlines the multidisciplinary approach that is needed. So, as rheumatologists, embracing and viewing these symptoms as an opportunity to improve the life of a person living with lupus. Thank you.